My name is Courtenay Holscher. I'm a general surgery resident at Johns Hopkins.
My name is Caitlin Hicks. I'm assistant professor of surgery in the Division of Vascular Surgery at Johns Hopkins.
And we studied utilization of peripheral vascular interventions in claudication patients. We were broadly looking at cost in medical care in the U.S. and we looked at claudication patients as a set of patients for which there's choosing widely an SVS shared campaign goal of avoiding peripheral vascular interventions as first-line treatment for newly diagnosed claudication patients. We looked at Medicare claims to see by physician what proportion of their newly diagnosed claudication patients were undergoing peripheral vascular interventions within the first 6 months of their claudication diagnosis. And what we found is that more than half of physicians performed 0 interventions for claudication in the first 6 months after a new diagnosis of claudication for their patients. But we did find that there were 6% of physicians who had a early PVI, early peripheral vascular intervention rate above 14%, or an outlier high rate of utilization of peripheral vascular interventions for their claudication patients. We found that the higher likelihood of early peripheral vascular interventions was associated with a lower volume of claudication patients diagnosed and with fewer years in practice, which we think suggests that there's room for education in care of claudication patients.
So the majority of specialties that we studied were vascular surgeons and cardiologists, because those are the primary specialties that perform these interventions. And after risk adjustment, there was no clear trends that one specialty performs more early interventions than another. The other interesting thing we found was that people who perform early interventions more frequently tend to practice in outpatient-based facilities or office-based labs rather than in hospitalized settings.
We did find that physicians practicing in a rural location were more likely to perform an early peripheral vascular intervention for their newly diagnosed claudication patients. There may be aspects of access to care involved with that, meaning when patients can come back and get care appropriately.
The other scenario is that in these low volume centers you're having less experienced physicians seeing these patients, and perhaps there's a level of educational opportunity to help inform the treating physicians to do better practice. So one opportunity I think that's ripe for the taking is to do some physician-targeted feedback. The Vascular Quality Initiative, for example, tracks outcomes and utilization of certain procedures on an institution level. We suggest that perhaps a provider-based level might be appropriate for certain physicians in this instance. Additionally, the Vascular SCORE curriculum, which is an online curriculum designed for surgical and vascular trainees, can be targeted, and in fact there is a new SCORE module targeting claudication and medical management of claudication that could perhaps be utilized to inform all physicians that are over practicing these procedures.
For all patients, the best place to start if you're having leg pain would be your primary care doctor, because there are lots of different reasons for leg pain, some of which are vascular causes. And that person is best qualified to evaluate and to refer you to the appropriate additional care provider, whether that's a vascular surgeon or another field.